Hello, my name is Bakshi Puneet, and today we will do complete cerebellar testing.
Hello, how are you?
I'm fine.
What is your name?
I'm Kiran Bakshi.
Today we will perform cerebellar testing. So we will just test your coordination.
Okay.
Okay.
Cerebellar system is the part of the motor system and it is responsible for the normal rhythmic movement and steady posture. To assess the cerebellar system, we have to assess the coordination. In this video, we will perform the rapid alternating movements, point to point movement, gait and other related body movement, and standing in a specified ways. Show the patient how to strike one hand on the thigh, raise the hand, turn it over, and then strike the back of the hand down on the same place. Urge the patient to repeat these alternating movements as rapidly as possible. Observe the speed, rhythm, and smoothness of the movement. Repeat with the other hand. The non dominant hand may perform less well. In cerebellar disease, instead of alternating quickly, these movements are slow, irregular, and clumsy, which is an abnormality called dysdiadokinesia. Now, in the next part, show the patient how to tap the distal joint of the thumb with the tip of the index finger, again as rapidly as possible. Again, observe the speed, rhythm, and smoothness of the movement. The non-dominant side often performs less well. Ask the patient to tap the ball of each foot in turn as quickly as possible on your hand or the floor. Note any slowness or awkwardness. Normally, the feet do not perform as well as hands. Dysdiadokinesia points to the cerebellar disease. Ask the patient to touch your index finger and then his or her nose alternatively several times. Move your finger so that the patient has to change directions and extend the arm fully or reach your finger. Observe the accuracy and smoothness of the movement and watch for any tremor. In cerebellar disease, these movements are clumsy, unsteady, and inappropriately variable in their speed, force, and direction. In dysmetria, the patient finger may initially overshoot the mark but then reach it fairly well. Now, hold your finger in one place so that the patient can touch it with one arm and finger outstretched. Ask the patient to raise the arm overhead and lower it again to touch your finger. After several repeats, ask the patient to close both eyes and try several more times. Repeat on the other side. Normally, the patient touches the examiner's finger successfully with the eyes open or closed. These maneuvers test positive sense and the function of both the labyrinth of the inner ear and the cerebellum. In cerebellar disease, incoordination modestly worsens with eyes closed, indicating loss of position sense. Ask the patient to place one heel on the opposite knee, then run it down the shin to the big toe. Observe this movement for smoothness and accuracy. Repetition with the patient's eye closed. Test for the positive sense. Repeat on the other side. In cerebellar disease, the heel may overshoot the knee and then oscillate from side to side down the shin. First, ask the patient to walk across the room or down the hall, then turn and come back. Observe the posture, balance, swinging of the arms, and movement of the legs. Normally, the balance is intact. The arms swing symmetrically at the sides, and turns are smooth. An uncoordinated gait with reeling and instability is ataxic. Ataxia is seen in cerebellar disease, loss of position sense, and intoxication. Next, ask the patient to walk heel to toe in a straight line called tandem walking. Tandem walking may reveal ataxia that is not otherwise obvious. Next, ask the patient to walk on the toes, then on the heels, This tests plantar flexion and dorsiflexion of the ankle as well as balance. Walking on toes and heels may reveal distal leg weakness. Inability to heel walk is a sensitive test for corticospinal tract damage. Next, ask the patient to hop in place on each foot in turn if the patient is not too ill. This tests proximal and distal muscle strength in the legs and requires both normal position sense and cerebellar function. Difficulty hopping points to weakness, lack of position sense, or cerebellar dysfunction. Next, at last, ask the patient to do a shallow knee bend, first on one leg, then on the other. Steady the patient if you think the patient might fall. Difficulty doing shallow knee bends suggests proximal weakness and weakness of the quadriceps, or both. This is mainly a test of positive sense. The patient should be stand first with feet together and eyes open, and then close both eyes for 30 to 60 seconds without support. Note the patient's ability to maintain an upright posture. Normally, any swaying is minimal. In ataxia from dorsal column disease and loss of position sense, vision compensates for the sensory loss. The patient stands fairly well with the eyes open but loses balance when they are closed, which is a positive test for Romberg sign. In cerebellar ataxia, the patient has difficulty standing with feet together, whether the eyes are open or closed. The patient should stand for 20 to 30 seconds with eyes closed and both arms held together straight forward with palms up. Normally, the patients hold this arm position well. If necessary, patient can be tested in a sitting position. Next, instruct the patient to keep the arms out and eyes shut and tap the arm briefly downward. The arms normally return smoothly to the horizontal position. This response requires muscular strength, coordination, and good position sense. Pronator drift occur when one forearm and palm turn inward and down and is both sensitive and specific for corticospinal tract lesion in the contralateral hemisphere. Downward drift of the arm with flexion of fingers and elbow is also seen.